Okay, in this video, we are going to talk about insomnias and parasomnias. We are going to discuss the management of insomnia in detail. We are also going to discuss a few parasomnias, nightmare, night terror, sleepwalking, sleep talking, REM sleep disorder. We are also going to discuss the management of these as well. First of all, insomnia is defined as a dissatisfying quantity or quality of sleep that leads to some form of daytime dysfunction. So either the quantity of sleep is dissatisfying or the quality of sleep. Both of these factors result in insomnia. Now, to understand the management of insomnia, you need to have a basic idea about the physiology of sleep, because in insomnia, that basic physiology of sleep is disturbed, and in the management and treatment of insomnia, we try to correct the basic sleep physiology. When you are awake, beta waves are active in the brain. And when you close your eyes, you enter the stage N1 of the sleep, the first stage of sleep, in which you are half asleep and half awake. And this is the stage of sleep where you get the hypnic jerks. Hypnic jerks are the jerks like these when you are sitting in a lecture and you are half asleep and half awake and you are doing this. This is the hypnic jerk that appears in N1 stage of sleep where you are half awake and half asleep. After N1 stage of sleep, you enter the N2 stage of sleep. N2 stage of sleep is a slightly deeper stage, and in the N2 stage, patients experience bruxism. In some patients, they have bruxism, they have teeth grinding, and teeth grinding takes place in N2 stage of sleep. Then comes the most deep phase of the sleep, and that is the N3 phase of sleep. In N3 phase of sleep, it is called as deep sleep phase, where there are slow waves in the brain and person is very difficult to awake in the N3 phase. N3 phase is usually the phase where the alarm keeps ringing and the person cannot wake up. That is the deep sleep. That is the N3 phase of sleep. And N3 phase of sleep is a very important phase in which sleepwalking occurs, in which in children bedwetting occurs. In N3 phase, night terrors occur in children. And N3 is a phase in which a person is difficult to wake up. In N1, the person can easily wake up. N3 phase is the phase of sleep where the body muscles are relaxed and the body takes rest. After N3 phase, then comes another phase called as REM sleep, rapid eye movement sleep. In REM sleep, there is a rapid movement of the eyes, and I have taken the graph upwards because in REM sleep, there is increased brain activity. The body gets paralyzed, the muscles get paralyzed, there is atonia, loss of tone, the person cannot move the body, and there is rapid movement of the eye. That is called as rapid eye movement sleep, REM sleep. And if you see the brain waves, if you take the electrical signals from the brain and see it under the graph, it will look that the person is awake, but the person is asleep. That is called as REM sleep, rapid eye movement sleep. In rapid eye movement sleep, there is memory processing taking place. Actually, the brain is on fire at this in this stage of the sleep, and all the memory processing and learning takes place in the REM sleep. Body is paralyzed, there is body paralysis, brain is highly active, eyes are moving, there are rapid movement of the eye, and memory processing and learning takes place in the REM sleep. Dreams that you have at night also occur at REM sleep. The dreams that you remember the next day are the dreams that occur in the REM sleep. And remember, the muscle atonia and muscle paralysis in which the body cannot move, it basically occurs because when you are having the dreams, and let's say in your dream you are fighting with somebody, so muscles are paralyzed, because if these muscles are not paralyzed, you will be fighting with someone in the sleep and you won't even realize. That's why dreams occur in REM sleep and body is paralyzed, so that you do not act out the dreams. Nightmares also occur in REM sleep. What is the difference between night terror that occur in N3 sleep and what is nightmare that occurs in REM sleep? We'll discuss it in the parasomnias. Now, after REM sleep, patient again enters into stage N1 of the sleep, and after REM sleep, it is easy for the person to wake up. After stage 1, person enters the stage 2 and then the stage 3, that is the deep sleep. So these are the different phases of sleep that occur at night. You enter into N1 stage, N2, N3, the deep sleep, in which it is difficult for you to wake up. Alarm keeps ringing and you do not wake up. Then you enter the REM sleep. In REM sleep, you have excessive activity of the brain, muscles are paralyzed, and there are dreams, there are nightmares in REM sleep. Then again you get N1, N2, N3, and then again you get the REM sleep. Now, as you go to sleep, you enter N1 stage, N2, N3, and it almost takes 90 minutes to enter the REM sleep. And remember, as the sleep progresses throughout the night, the duration of REM sleep keeps increasing and the duration of deep sleep keeps decreasing. The deep sleep decreases and REM sleep keeps increasing. And it is easier for you to wake up when you are in the upper part of the graph. When you are soon after the REM sleep, it is easier for you to wake up. And when you are in the deeper phase or when you are in the lower part of the graph, it is difficult for you to wake up. Now, when you are sleeping at night, the REM sleep keeps increasing, and soon after the REM sleep, you usually wake up in the morning. In the REM phase, you are having the dreams, and soon after the REM sleep ends, you wake up. Because as I said, in the upper part of the graph, it's easier for you to wake up. As soon as you are having the dreams in the morning, and then you wake up. That occurs after the REM sleep. And sometimes even you wake up before the alarm bell has rung. Before the alarm bell rings, you wake up. That occurs at the end of the REM sleep. You wake up. Now, another important phenomena that you must know about is sleep paralysis that occurs in REM sleep. Now, as I said that in REM sleep, the body is paralyzed, and if someone wakes you up or if you get awake in the REM sleep, your body will be paralyzed and you will be awake and you will try to move, but you won't be able to move your body. That is when you wake up during the REM sleep. That is sleep paralysis. It's a normal phenomenon. Now, coming to an important pharmacologic correlation, alcohols, benzodiazepine, barbiturates decrease the REM sleep. They decrease the N3 phase of sleep. And remember, the two most important phases of sleep are the N3 phase of sleep, the deep sleep in which the body takes rest, and the REM sleep. In REM sleep, memory processing and learning takes place. And if these two phases of the sleep are deficient, the next day you will feel that you have not rested well. You will feel sleepy. You will not feel well rested. That's a dissatisfying quality of sleep. So alcohol and benzodiazepines, they help induce the sleep, but the problem is that they reduce the N3 phase and REM phase of the sleep. People who are suffering from insomnia have the tendency to take more alcohol to help induce the sleep, or they take benzodiazepines to help induce the sleep. But the problem with benzodiazepine and alcohol is that they reduce the N3 and REM phase of the sleep, and if a person takes alcohol to help induce sleep, the next day the person would feel hangover and the quality of sleep is compromised. The quality of N3 and N sleep is compromised. If a person takes benzodiazepines to help induce the sleep, the next day he will feel sleepy. He will not feel well rested because the quantity of N3 and REM sleep is decreased. Now, some physiological changes take place with age. In elderly, REM sleep decreases, N3, the deep sleep, decreases. So these elderly patients are easy to wake up and they have increased sleep latency. It takes a lot of time for these patients to go to sleep. Sleep latency is the time period from which you enter the bed and you fall asleep. So it takes a lot of time for the elderly people to fall asleep. The sleep latency is increased and the quality of sleep also decreases, and they are easy to wake up because REM sleep and N3 sleep is low, and they have early morning awakening that is called as terminal insomnia. Now, coming to changes in depression. In patients with depression, there are some changes that take place to the sleep physiology. Their REM sleep increases, their REM sleep latency period decreases. What does REM sleep latency period means is that when they fall asleep, the period from falling asleep and entering the REM phase is usually 90 minutes in normal individual, but in depressive patients, they directly enter the REM sleep. Their latency period is short and they quickly enter the REM sleep and they are dreaming about things then. They have decreased deep sleep. They do not enter the deep sleep phase of the sleep and therefore they are easy to wake up at night. They have repeated nighttime awakenings because they enter the deep sleep for a very short period of time. They have decreased deep sleep, and they have a classical thing called as early morning awakening, terminal insomnia. In the patients with depression, these are the patients who usually fall asleep quickly, but they keep waking up at night again and again, and they have terminal insomnia. If they have set the alarm clock at 7 a.m. in the morning, they will be awake lying in their bed at 4 a.m. and they will be awake for the next 3 hours. That is called as terminal insomnia, and that is these changes are seen in patients with depression. Usually the patients with anxiety, they will have difficulty falling asleep, and once they are asleep, they will be fine throughout the night. But the patients with depression, they will have the difficulty in maintaining the sleep. They will fall asleep quickly, but they will have a difficulty in maintaining a proper sleep. Now coming to the management of insomnia. In the management of insomnia, once you understand the sleep physiology, it's very easy for you to treat these patients, because according to the cause, according to the etiology, according to the stressor, you treat the patient. And the first and the foremost thing is, the first line treatment in all patients is always cognitive behavioral therapy, in which you address the stressors. That what are the stressors, whether it is depression, whether it is anxiety, what is causing this insomnia. So you address the stressors and you advise the patient a sleep hygiene. What is sleep hygiene? You ask the patient to have regular bedtime and rise time. You ask the patient to avoid napping during the day. You limit the caffeine intake of the patient, especially near the last hours of the day. You limit the alcohol intake. As I said, alcohol induces the sleep, but alcohol decreases the N3 and REM phase of the sleep. You ask the patient to avoid smoking, avoid nicotine, especially near the end of the day, because they are stimulants and they increase the chances of insomnia. Exercise 4 to 6 hours before the bedtime. Quiet, dark room for sleep. You ask the patient to avoid checking clock. The problem is that the patients who are having insomnia, all throughout the night, they just keep checking the clock and they keep checking the time, that this much time has passed and I haven't yet fall asleep, and they are thinking that these many hours are left for me to sleep, and now these many hours are left for me to sleep. So you ask the patient to avoid checking clock. Even if they are not having the sleep, they should not look at the clock. Bed should only be used for sleep or sex, for the relaxing activities. Basically, our mind creates an association. If you are studying in the bed for a longer period of time, your mind creates an association that this is the place where your mind should be active. So you study on the study table, you perform the stressful activities outside your bedroom, and when you come to bedroom, this must only be for sleep or sex. Your mind should have an association that this is not the place of stress. Breathing with diaphragm. You ask the patient to breathe with diaphragm, breathe with abdomen, and relax themselves so that there is more parasympathetic stimulation and person can fall asleep. Avoid using mobile phones, tablets, or laptop before the bedtime, because they increase the stimulation of brain. You should wait to go to bed until you feel sleepy. If you are not feeling sleepy, you should not go to bed, and you should wait for your body to feel tired, then you should go to bed. If you are unable to sleep within 20 minutes, if you are lying in the bed and you are unable to sleep, then what you should do is that you should leave the bed and you should sit somewhere else quiet. Basically, when you keep lying in the bed for a longer period of time, it increases the anxiety that why I am not able to fall asleep. All the world is feeling asleep and I am still awake in the bed. So what you do is that you should leave the bed after 20 minutes if you are unable to sleep. Now you will be thinking that I asked you not to check the clock, and now you are saying that you leave the bed after 20 minutes. So you get a basic idea that a lot of time has passed and I am still unable to fall asleep. You should leave the bed, you should sit at somewhere quiet and return only when you feel sleepy. Now coming to acute insomnia. Acute insomnia is the one that lasts for less than 1 month, for few days, for few weeks. Now this acute insomnia always occurs. There is always a stressor behind acute insomnia. There is always some stress in the life that that person is going through that is causing increased anxiety, and anxiety causes increased brain stimulation, and whenever there is increased brain stimulation, patient will not be able to sleep. So you address the stressors. Usually in the students who are having their exams, they are unable to sleep because they are having the stress or anxiety. There is no pathology, there is no disease that they are suffering from. It's just the anxiety, the psychological part. They are not relaxed, they are anxious about the exam. That's why there is increased brain stimulation and they do not fall asleep. So the management is twofold. You address the stressors, that's the main thing. You advise sleep hygiene, and if after addressing the stressors, after advising the sleep hygiene, if the patient is unable to control insomnia, then in acute insomnia you need to give medications, because in that stressful period, if they are unable to fall asleep, their mind will take a stimulus that person cannot fall asleep when he goes to bed. So that acute insomnia, if not managed properly, can convert into a chronic insomnia. So you manage the acute insomnia so that it does not convert it into a chronic insomnia. For the pharmacological therapies in severe insomnia with substantial distress, to get through the exams, to get through that difficult period of life, you help them with some medication if the initial therapy sleep hygiene fails. Short-term medication course can be given. What medications are given? I'll discuss them in chronic insomnia management. Same medications are used in acute insomnia. Now coming to chronic insomnia, insomnia lasting for months and even more, that is chronic insomnia. Remember, in chronic insomnia, it's usually the episode of acute insomnia in a stressful period, in a period where the patient is in extreme anxiety, extreme stress, either due to exams or due to anything. In that period, if the acute insomnia is not managed properly, that their brain will think that they have some problem and they cannot fall asleep, and they keep consolidating that fact every night. They feed their to their brain that they are unable to fall asleep, and then that acute insomnia gets converted into a chronic insomnia. So the main treatment, the first line treatment, is cognitive behavioral therapy. You need to address the psychological factors. You need to dig out for the anxieties. You need to dig out the causes of depression and address those. They will result in the treatment. And if the cognitive behavioral therapy fails, then you can go for pharmacologic therapy, and you can help the patient with pharmacologic therapy, but you cannot continue the patient indefinitely on the pharmacological treatments. The main treatment is always cognitive behavioral therapy, addressing the stressors. Now, for acute insomnia as well as chronic insomnia, when you are about to initiate the pharmacologic therapy, you need to see that whether that patient is having isolated sleep onset insomnia. As I said, in patients who are suffering from anxiety, they have sleep onset insomnia. It's difficult for them to fall asleep, but once they have fallen asleep, the sleep quality is good. The other thing is sleep maintenance insomnia or mixed insomnia. In sleep maintenance insomnia, usually the patient falls asleep, but that patient cannot maintain a good quality of sleep, and that patient keeps waking up throughout the night, and patient has terminal insomnia, as occurs in the patients with depression. If the patient is having isolated sleep onset insomnia, it takes greater than 30 minutes to fall asleep, or maybe patient is awake for the whole night or a half night, and once asleep, quantity of sleep and quality of sleep are good. It is difficult for the patient to fall asleep, but once the patient falls asleep, everything is fine. In sleep maintenance insomnia, patient may fall asleep quickly, or patient may have increased time to fall asleep, but when the patient has fallen asleep, the patient keeps waking up throughout the night. Difficulty sleeping through the night, greater than 30 minutes awake in the middle of the night, or waking up too early, terminal insomnia. Sleep onset also greater than 30 minutes. If the patient is having isolated sleep onset insomnia, the first line medications include melatonin receptor agonist. Melatonin is a hormone that is produced from the brain when you are present in the dark, and it makes you feel sleepy. That's why staying in the dark room was environment. You turn off all the light and you go to bed, because that stimulates the melatonin secretion. So you give drugs that stimulate the melatonin receptor, and that include remeltion. Other off-label, over-the-counter drugs that can be used for the treatment of insomnia in these patients is melatonin. Over-the-counter diphenhydramine, doxylamine. Diphenhydramine and doxylamine are basically antihistamines, and they are sedative antihistamines that induce sleep. Sedating antidepressants, especially in the patients who are suffering from depression, these drugs can be helpful because they treat the depression, they treat the core issues, and as well as they also induce sleep. Mirtazapine can be used. Short-acting benzodiazepines can be used like triazolam, but as I said, that benzodiazepines reduce the quality of sleep. So you can only use the short-acting benzodiazepines that can induce the sleep, but after that they have no effect. In the long-acting benzodiazepines like diazepam, these long-acting benzodiazepines reduce the N3 and REM phase of sleep. Benzodiazepines have high risk of dependence and habituation, so you should avoid benzodiazepines. If the patient is having sleep maintenance or mixed insomnia, the first line drugs is dual orexin receptor antagonist. Basically, orexin is a compound that is produced during the day, and orexin stimulates the brain and it causes the brain to be more active. During the day, orexin is secreted, and that orexin makes the person more awake and it asks the patient to be more active. So you give drugs to block that orexin hormone. You block the receptor where the orexin binds so that the brain gets sleepy. Dual orexin receptor antagonists like daridorexant, lemborexant, suvorexant, these are the drugs that can be used. Low dose doxepine can be used. Doxepine is basically tricyclic antidepressant. It addresses the core issues and it also causes sleep. In these patients, you can also use non-benzodiazepine receptor agonists. Now, there are certain drugs that are not benzodiazepines. They do not have the addiction potential like benzodiazepines, but they stimulate the benzodiazepine receptors and they cause sleep. They include zolpidem, esozopiclone, zeliplon. So these are the drugs that can also be used to avoid benzodiazepine use. You can use these drugs because these drugs have lesser addiction potential. Herbal, off-label or over-the-counter drugs that can be used in these patients are sedating antidepressants like amitriptyline, a tricyclic antidepressant, mirtazapine. Mirtazapine causes weight gain, so you should avoid it in patients who are having obesity. And you should use these antidepressants in the patient in which the core issue is depression, because you can kill two birds with the same stone. You treat the depression and you treat the insomnia. Over-the-counter antihistamines like diphenhydramine, doxylamine can also be used. If the patient is having comorbid depression, you can use mirtazapine, trazodone because they treat the depression as well as insomnia. Now coming to parasomnias. In the parasomnias, the most important one is nightmares, the bad dreams people get. These bad dreams are these terrifying dreams occur in the REM sleep, and whatever occurs in the REM sleep, you remember it the next day. It occurs in the middle of night or in the early morning. Patient remembers the dream next day and there is no tone. That's why the person cannot act out the dream. The treatment is you address the stressors, that what is disturbing their sleep, because in the treatment you address the stressors. In a normal quantity, nightmare is fine, but if the nightmares are extremely disturbing, then you should address the stressor, because basically there is psychological stressor that is disturbing the sleep and causing nightmares. If there is concomitant PTSD, usually these patients with nightmares have a post-traumatic stress disorder. Maybe they had an accident, maybe maybe if it is a soldier, he was in a war, he has those nightmares of those soldiers being killed, or those deaths, or those traumatized events, memories come back at night and they cause nightmares. So it's always the psychological stressor. You address that psychological stressor, and if there is concomitant PTSD, you treat it with SSRIs. Now coming to night terror, I'll give you an example. In the middle of the night, the child wakes up, sits up, and the child starts screaming, and then the child goes back to sleep. The next day when you ask the kid that what happened last night, the kid won't remember anything, because the night terror occurs in the N3 phase of the sleep, and in the N, whatever happens in N3 phase of the sleep, you don't remember it the next day. So it occurs in N3 phase of the sleep. It is a deep phase of sleep, and patient remembers nothing, the kid remembers nothing. And in the deep phase, there is a tone of the body, therefore the kid sits up and screams. So it yells, screams, and goes back to sleep and remember nothing the next day. Parents are worried. Parents bring their kids to the clinic. You reassure them and tell them that no treatment is required. In very refractory cases, benzodiazepines can be used, but avoid benzodiazepines. Just reassure the patient that it will be okay. Patient is not getting affected. Patient even does not remember that he had a night terror last night. Sleep talking, incongruent speech. Patient does not reveal secrets in sleep talking. So be happy for that. REM sleep behavior disorder. In REM sleep behavior disorder, normally in REM sleep, as I said, patient is dreaming and the body tone is paralyzed. Body is paralyzed in REM sleep. In REM sleep behavior disorder, this paralysis is lost and patient starts acting out the dream. If the patient is fighting with someone in a dream, the patient will be fighting at night when he is asleep. That is called as loss of REM sleep atonia. Physically acting out dreams, yelling, moving limbs, punching and walking, and it is very problematic for the partner. Management includes removing the dangerous objects from the room, and first line drugs include melatonin receptor agonists, and the second line include benzodiazepines. Before going into the summary, if you liked my video, please click on the subscribe button. What is insomnia? What are the different phases of sleep? REM sleep, deep sleep, how the REM sleep phase increases, sleep paralysis, alcohol, benzodiazepines effect on sleep, changes in the elderly, changes in the depression, management of insomnia, sleep hygiene, acute insomnia management, chronic insomnia management, the medications that you can use, off-label drugs, the different drugs that are used for management of chronic insomnia, comorbid depression treated with antidepressants, what are the different parasomnias, nightmares, address the stresses, nothing to worry about, night terrors in kids, nothing to worry about, sleep talking, and REM sleep behavior disorder must be treated. If you liked my video, please click on the subscribe button and check out my other videos on emergency medicine and neurology lectures. The link of those videos is given in the description below. Thank you very much.